Thanks so much. It's actually lovely to be asked to speak. You know, I'm your president-elect for ISAM, so I'll take over the presidency in Abu Dhabi, and I'm just so proud to be part of this organization and just love seeing the groups get bigger every year and really enjoy the diversity of this group. So as you heard, I'm from Charleston, South Carolina. This picture right here is our beautiful university perched on the harbor. Just thought we'd show this in case we ever want to have an ISAM meeting in the United States. This might be a spot that people would enjoy. It's actually really beautiful. I also want to begin by just thanking my colleagues. I'm going to present a lot of work from other people at MUSC. I'll try to acknowledge them as I do. My family, who's put up with a lot, and friends and NIH, all the work of my group that you'll see on these slides here has been funded by NIH. So addictions, as we know, probably more than any other disorder that we deal with, really truly is a biopsychosocial disorder, one in which we know it is a brain disease for sure, but it's got lots of environmental, both precipitants, and then it has a lot of impacts on the environment. Certainly has a medical underpinnings and medical consequences. So, and one of the issues that, I think it's not so much an active question, but when you talk about the area of stress and addictions, this whole idea of nature versus nurture in addictions, are people just born with the predisposition and that all they need is the right environment, they're going to become an addict? Or are there some environmental circumstances that actually make it inevitable for some individuals to develop addiction? And stress and exposure to high levels of stress is one of those environmental conditions that one might wonder about in this regard. One of the things I noticed sort of from the very beginning of my career in addictions, which I hate to say, 30, 35 years, interviewing lots and lots and lots of people with addictions as a resident and junior faculty, is, my goodness, traumatic exposure is really, really common in the lives of people with addictions. Much, much, much more common than it is in the general public. And often it was the kind of traumatic exposure. Sometimes it's that traumatic exposure that's a result of the risky lifestyle that goes along with addictions, but often it was traumatic exposure that had nothing to do with addictions: childhood exposure, domestic violence, combat exposure, and its association with the development of addiction. So we started to just sort of look into this stress addictions connection. This is, again, as I said, about 30 years ago. And at that point, it had a lot of intuitive appeal. And if you ever, when you talk to people with addictions, they'll tell you, "Doc, I was doing just fine, and then my wife left me, or I lost my job." But you probe that situation a little bit more, and what you find out is, the wife left because the drinking had been going on for about 30 years. And, so it's the causality, in any individual case can be a little bit hard to establish. But two things, even way back then, were very, very clear in the literature, and that is that childhood adverse events are strongly associated with the development of substance use disorders. And I'm not going to talk today about all of the evidence for that, because that evidence has just done nothing but accumulate over the years. I'm going to talk a little bit about the neurobiology of it, but not the evidence. I'm assuming everybody here is probably pretty convinced of that. I think the other thing that we know for sure from epidemiologic surveys and as well as looking at treatment-seeking samples of individuals is that PTSD and mood and anxiety disorders are strongly associated with substance use disorders. So if you have, and I'll show you some of the epidemiology, if you have a mood or anxiety disorder or PTSD, you're anywhere between 2 and 6 times more likely to have lifetime substance use disorder compared to somebody who doesn't have a mood or anxiety disorder. This is particularly true for PTSD, which is the disorder. It is sort of the sine qua non of a stress disorder, because you need a stressful life event in order to meet criteria. If you look at individuals with PTSD, about 30 to 40% have substance use disorders, maybe higher in combat related. If you look at substance use treatment seeking samples, about 20 to 60%, depending on when you do the diagnostic interview and the population that you're talking about, will have PTSD. It appears to be higher in women, higher in cocaine and opiate users, although the alcohol literature is certainly catching up now. And every epidemiologic survey that has been done has shown increased odds for the co-occurrence of PTSD with alcohol and drug use disorders. And those odds ratios are usually somewhere between 3 and 6. So people with PTSD are 3 to 6 times more likely to have a lifetime substance use than people without it. And these odds ratios are higher in general for women. So it looks like the strength of this relationship between stress, stressful life events, and the development of substance use disorders is stronger for women than it is for men. And I'm going to show you some more evidence, some neurobiologic evidence in that regard too. So I'm hoping that we all agree at this point that it is a non-random association. And just to talk a little bit more about the gender differences in the stress addiction connection, before we were doing a lot of neuroimaging and that sort of thing, I'll tell you a little bit about our laboratory paradigms. We bring people into the laboratory. Usually it's people with addictions and a control group that looks like them, age, gender, all that sort of stuff, but don't have addictions. And then we'll expose them to cues that are related to their substance use or other stressors. Sometimes we'll do pharmacologic stressors. And we measure craving and HPA axis and other things for an hour or two after. And then we see them again in a couple of weeks to see if anything that happened in the laboratory relates to their drinking or drug use in the time since they left our lab. And so from some of those studies, one of the things that we had, some conclusions that we and others had come up with is that women definitely have, and this is across substances of abuse, I'm talking nicotine, alcohol, cocaine, greater craving to negative emotional cues compared to men. Women also are much more likely, again, across a number of studies, to endorse stress and interpersonal conflict as a relapse precipitant. And men, again, in these human laboratory and other just sort of by historical recounting, are really more responsive to drug-related cues in terms of their relapse. So this was part of our beginning to think about the stress addiction connection in particular for women, and or as stronger for women. And then I just want to show, so of course, I think Mark pretends a baby here, but this was a lovely study done by his group, published in 2012. And what we're looking at is neuroimaging here. And on the left side, you're looking at women, right side, you're looking at men. And on the top two, this is personalized stress scenarios. So they're read while they're in the scanner, a personalized story of an event that was stressful to them. In the bottom, while they're in the scanner, they are presented with drug cues, either visually and through a story of drug cues that are personalized to them. And what you see is this is the cocaine-dependent women versus healthy control women. Look at the areas that really light up, all those limbic areas, the areas we know are involved in drug abuse and craving, to stressful situations, but not necessarily to the drug cue. And if we look at our cocaine-dependent men, we see little activation with the stress, much more activation with the drug cue. So again, just neuroimaging evidence of the same thing that we had been looking at in the laboratory. This is a more recent study done by one of our postdocs that I just think is curious. In that it shows gender differences again. The difference in this neuroimaging study here is they're not talking about, they're not showing people personalized scripts or personalized images. This is just, it's from the IAP, so it's just pleasant versus unpleasant images. And what you see here on one side is controls versus cocaine users, their response to pleasant images. And what I want you to notice there is that cocaine users in general are sort of anhedonic, not nearly as much response to pleasant, and that's for both men and women, not nearly as much response to pleasant images. And if you look at the other side, we're looking at unpleasant images. And a curious thing, considering this stress connection with women, is that, again, controls are much more responsive to unpleasant images as well. But cocaine users, you can see that the women in particular are showing more sort of anhedonia as well, to, or at least inability to respond to these unpleasant images. The men, there's less of a difference, definitely significant difference between cocaine-dependent women and the control women in this regard. So one of the things, we do a little bit of neuroimaging, but we do a lot more human laboratory stuff, which is what I'm going to talk about now. And if you are curious about this interaction between stress and addictions, what are the systems that you might look at? Well, you probably want to look at systems that are involved in stress and some that we also know are involved in addictions. And you'd want to look at systems that you can sort of relatively easily measure, where we've got biomarkers in the periphery and that sort of thing. So the system, the HPA axis is certainly involved, extra hypothalamic CRH systems that really act directly from directly when one is stressed. CRH is released not just through the HPA axis, but it's released and acts directly on the locus coeruleus and the amygdala and other areas to have a much more immediate stress response. Certainly the locus coeruleus, norepinephrine, the fight or flight system is another system that we can measure. And then obviously dopamine, serotonin, GABA, glutamate, just about every system is involved in the stress reaction. But the ones that I'm going to talk about today are the ones that we've been measuring, which is those top three. And I know this is probably very familiar to everybody, but just to sort of go through this, so when I use acronyms and abbreviations, you'll know what I'm talking about. This is the HPA axis. From the hypothalamus, CRF, or corticotropin releasing factor, is released under stressful circumstances and other circumstances, probably with drug use. It goes to the pituitary, where from the anterior pituitary you get the release of ACTH. At the same time, however, and I'll get back to this, from the posterior pituitary, you actually get the release of oxytocin and vasopressin, which are also released, and they're almost the anti-stress hormones released at the same time as ACTH. ACTH goes to the adrenals, where it causes the release of cortisol. Well, this is a tightly controlled system with really exquisitely controlled feedback loop, so that cortisol feeds back at the level of the pituitary and the hypothalamus to sort of decrease the stress response. That's one of the things that happens. You want a really good, swift response to a stressor, and then when the stressor goes away, you want to get back to normal. You don't want to be on high alert if there's no reason to be on high alert, because you're using all sorts of energy sources, and you're using resources that you don't need to use if you stay on high alert. And that's one of the problems with PTSD, is there's a lot of dysregulation in this system, and norepinephrine, epinephrine, the fight or flight system seems to be on overdrive and stay on overdrive in inappropriate situations in PTSD. One of the other things that happens, though, with the stressor is CRF. As I said, there is a more direct link directly to the locus coeruleus, where the epinephrine, norepinephrine release, and that acts within a minute or two. It takes about 20 to 30 minutes for cortisol to peak after a stressor. It takes about 2 to 3 minutes for your norepi response to peak. So we have a very nice, I feel really lucky at MUSC. We've got a great group of basic scientists that we work very closely with. And we've been working on this stress addictions connection with our basic scientists. One of the nice things is, and it really is an iterative process, we find things and ask them to do it in the lab, and they can do it so much quicker. Some of the things that they find, they bring forward, and it'll take us a couple of years, but we'll run a human study on it. And one of my favorite models that they do a lot of work with is these animal models of relapse or reinstatement models. And basically the way these work is, you teach an animal to take a drug. I mean, and animals will take almost, they'll take cocaine. You can teach them. They will self-administer these reinforcing drugs, cocaine, opiates, you name it. And then you extinguish it. So they may be pressing the lever for the drug, and you throw them in that box a few times, and the lever is inactive. Pretty soon they stop pressing the lever. They're not interested in it anymore. Then, after they've been extinguished, they're not pressing the lever anymore, there are a couple of things that you can do to make it more likely that if you throw them back in the box, even after they've been extinguished, they're going to run right over and just try the lever, see if it'll work again. One of the things that you can do is give them a little taste of the drug that they were previously self-administering. That's drug-primed reinstatement. One of the things you can do is, if there's always a blue light on when the drug was available, you put the blue light back on, and that's what we call a cue-induced reinstatement, or an environmental cue that was associated with the availability of the drug. And then the third thing that you can do is stress-induced reinstatement. And this is a very robust paradigm. It works across species. You can do all kinds of stressors, foot shock, forced swim, isolation. Again, do that. Put the animal back in the box, and they are much more likely to run to that lever and try to self-administer drugs. And pharmacologic and surgical manipulations have actually shown, while there is convergence on the nucleus accumbens as the final common pathway for these drugs of abuse, you can actually tease apart upstream from that these three pathways of abuse. There are different neurobiologic pathways involved with these different types of reinstatement. And when it comes to stress-induced reinstatement, there's a couple of things we know. It's blocked by CRF antagonists. It's induced by CRF agonists. So we know that CRF, either through the HPA axis or extrahypothalamic, is involved. It's blocked by blocking beta receptors in the amygdala and the bed nucleus of the stria terminalis. So the noradrenergic system is also involved in stress-induced reinstatement. And it's increased by, so if an animal's had a lot of previous drug exposure, they're much more vulnerable to stress-induced reinstatement. So I've already told you about our human laboratory settings, and I'm going to now show you a little bit of data from these human laboratory studies that we've been doing. We do, the stress exposure that we use is either a psychological stress, which is a trier, a social speaking task in front of strangers, physical stressor, or pharmacologic. CRF, we actually administer corticotropin releasing factor, or yohimbine, which is an alpha-2 antagonist, which increases the amount of norepi available at the synapse. So it's actually an alpha, it increases noradrenergic tone. So this is just craving and the response to CRF. The two lower lines are control males and females, and the graph on my left is the craving when you administer CRF. What's really interesting here is on a 1 to 5 scale, look at our cocaine-dependent males and females. They really crave when you give them CRF. It's as if, so this stress system is very closely, intimately related to their sensation of craving for cocaine. In the right panel, bottom lines are the control groups. Top line is cocaine-dependent males and females, and what we're looking at there is their anxiety. So you can see there's a little bit of anxiety even in the control group, but more. So it's as if these cocaine-dependent individuals are very sensitive to CRH, more sensitive than controls, and it does precipitate craving. This is looking at the correlation between ACTH and cortisol. Okay, if you've got a really nicely a very well-controlled HPA axis response. Cortisol and ACTH are going to be very nicely correlated. And if you look at that, because one causes the release of the other, if you look at your control males and your control females, there's pretty good correlation there. You look at your cocaine-dependent males, the correlation is not so good, significantly less correlation than in cocaine-dependent males, indicating dysregulation. You look at your cocaine-dependent females in that bottom right corner, there's absolutely no correlation, which indicates much bigger dysregulation in the HPA axis for these cocaine-dependent females. And then if we look at the heart rate responding, this was one that really got us thinking. We are looking at that top line, the dotted line is the cocaine-dependent females. The one right below it is the cocaine-dependent males. And then there's the control group. So what you can see in these cocaine-dependent females, not only is it a more robust response, CRF, but also it doesn't get back to normal as it should in a timely manner. They stay elevated. Their heart rate is up 2 hours after, after they got the stimuli that provoked the increased heart rate. So this got us thinking about two things. One is that there was something different about the females. Number two, because this was such a rapid response, and it really was because it was heart rate, which is under noradrenergic control, we thought this is probably extra hypothalamic CRF activity, not through the HPA axis. So what did we decide to do about those gender differences? One of the things we did is go back to our basic science colleagues and say, using your reinstatement models, would you guys look and see if there's gender differences? We think there's gender differences in the impact of CRF, and this is a study by Ron C. and his colleagues. The dark bars there are the females, and what you can see is that the females are, and what we're looking at on the y-axis is lever presses, which means that they are running to the box and trying to self-administer cocaine in this case, and you can see that the females are these female rodents are more responsive to CRF than the male rodents. So that was part of our reverse translation. And then again, because I said this heart rate stuff seemed to us this was probably more noradrenergic than HPA axis, so we started to take a look at probes of the noradrenergic system. Yohimbine, as I said, is a drug that actually increases noradrenergic tone, and what you're looking at here is anxiety and craving after yohimbine. The top bar, I'm sorry, they both say anxiety. The one on my right is craving. Top bar is your cocaine-dependent females. Middle bar is your cocaine-dependent males. So you can see that the cocaine-dependent females have a much more robust response to this noradrenergic probe in terms of both craving and anxiety. So once again, we went back to our basic science colleagues and said, hey, we think yohimbine, we think the noradrenergic system is more sensitive in our cocaine-dependent women than men, and you can use yohimbine that can be a chemical stressor for reinstatement. And again, we're looking at the same thing here. Males, in this case, dark bar, females, lighter bar, and you can see that yohimbine enhancement of Q-induced reinstatement was stronger in females compared to the male rats. So the next thing we decided to do was say, okay, so how about the therapeutic, potential for this? If we tweak the noradrenergic system, how about if we dampen down the noradrenergic system? Will this do better in terms of decreasing craving in women than men? This is not our data. This is data from folks at Yale, and what we're looking at is guanfacine, which is an antihypertensive that is an alpha-2 agonist. And what you can see is looking at craving and cocaine craving across a couple of different imagery conditions. You can see that and the striped bar there is the guanfacine. You can see that for females, guanfacine actually decreased craving. For males, not a significant increase, but certainly no change. So it looks like these females are more sensitive in terms of decreasing craving to noradrenergic agents. Then this other study came out, which there's no gender analysis here, but I think is very interesting in terms of the stress relapse connection. And just really, you know, my thought is, could it be that simple? Is it really just tweaking the noradrenergic system, which we know how to do? This was done at Hopkins, I think. 118 opiate-dependent subjects are all on buprenorphine, but they're randomized to adjunctive placebo or adjunctive clonidine. Clonidine is another antihypertensive agent that actually decreases noradrenergic tone. The other thing they did that was so interesting is they gave them smartphones, and periodically during the day they would say, how are you feeling? Have you been stressed? Are you craving? So that's what we call, you know, ecological momentary assessment. So they could look at the relationship between stress and craving in this group on clonidine versus placebo. And this is what they found. They found this is a survival analysis here. So on the y-axis, we're looking at time to relapse. On the y-axis, we're looking at relapse. On the x-axis, time to relapse. What you can see, that green bar, that's the clonidine group. So the clonidine group actually had longer time to relapse and less relapse than the placebo group, which is the orange bar. And then if you look at the ecologic momentary assessment stuff, again, I wish I had a pointer here. What you can see is under the one place where these two really separate, the orange, this is, are you craving under stress? And you can see that orange bar, the orange line, where there's under moderate stress, the clonidine group is reporting no craving. The placebo group is reporting a lot of craving. So it looked like some of this relapse prevention, at least. And the next graph over is just looking at Q-induced craving, and you can see there's not much difference between the placebo and clonidine in Q-induced craving, but there is in stress-induced craving. But the unfortunate thing, there's no gender analysis there. I'd love to see if that effect is stronger in women than men. But one of the other things I just wanted to talk a little bit about is this whole area of childhood events and how it is that childhood events could impact the response to stress and drugs so much later in life, and how and is it possible that impact is stronger in women than men, and if so, why might that be? And there's some new evidence that to bear on that, I think. Well, one of the things for sure is this whole area of epigenetics, which could not be, I think, honestly, the drug abuse and psychiatric field has some of the most to benefit from the study of epigenetics, which is basically environmentally induced changes in DNA expression. So those histone bodies that hang off the chromatin can either be methylated or acetylated by environmental precipitants, and that can cause either greater expression of the protein that is encoded for by this DNA, or less expression of that protein. And it also, I think, gene by environment interactions also are impacted by this, because as you can imagine, different polymorphisms of genes may be more susceptible to epigenetic changes. I mean, that may be how gene by environment interactions actually occur. So if you were to say, I'm interested in gene by environment, I'm interested in epigenetics, what gene system might you look like, or you know, what physiologic system might you want to look at to see about changes? And certainly CRF and the expression of CRF would be very important. So let me just, this slide here just shows one of the first human studies actually showing the importance of epigenetics. We're looking at methylation. This is post-mortem samples. We're looking at methylation in a control group versus a suicide group that did with no evidence of childhood abuse, and a suicide group with clear evidence of childhood abuse. And we're looking at methylation in the hippocampus, and you can see clearly that childhood abuse appears to be associated with increased methylation. But this is, so as I said, the CRF system is probably the one might be interested in looking at. And there's probably about 4 replications of this right now, but there are functional polymorphisms of the CRH receptor. And what we're looking at here on the y-axis is lifetime heavy drinking, and on the x-axis are 2 different types of, let's just call it the resilient and the vulnerable subtype of CRH polymorphisms. And this is a study in which they looked at the number of negative life events and how did that impact lifetime drinking. And what you can see in that group that's on my left, the dark bars are people that have many negative lifetime events. The light bars are people that don't have much lifetime trauma. So you can see, if you don't have much lifetime trauma, it doesn't matter what your CRH, which type of CRH receptor you have, your drinking isn't impacted. But if you have a lot of lifetime trauma and happen to have the homozygous Z subtype of the CRH receptor, you are much more likely to develop a drinking problem. And as I said, there's probably 4 or 5 studies now that have shown this in different ways, that this particular polymorphism seems to be very important in terms of the relationship between stress and drinking. So as I said, there's a very recent interesting study that actually showed, this is in rodents, but I think could be very interesting, sex differences in the nucleus accumbens transcriptome following stress. So in this study, there was chronic stress led to markedly different patterns of stress regulation of gene reception, gene expression. In the females, there were many more signs of depression and much greater methylation. And with the females, if they did a knockout, if they did this same stress paradigm with knockout methyltransferase, so they could not methylate, what they found was this enhanced the resilience of these female animals. So very interesting. One of the first studies I am aware of that looks at really gender differences in epigenetic changes. So just to conclude that, let me just say, like most complex diseases, it's really not a nature versus nurture, but it is nature plus nurture that is involved in the development of addictions, and stress is extremely important, stressful life events. I just want to spend the last few minutes saying, we don't just spend all our time tormenting people in the lab. We're also very interested in using what we find in the development of therapeutics. So we're very interested in resilience. And if you guys haven't read this article, this was one of my favorite articles of all times. It's old now, Dennis Charney, 2002, but it was the neurobiology of resilience. And I must have worn that copy out. But one of the things that I really loved about it, just looking at all these chemicals and what's involved in the neurobiology of resilience. But of these, there was only one that we thought that we could clearly administer in the laboratory setting and take a look at more carefully, and that was oxytocin. And so we've done a series of studies with oxytocin. Oxytocin, as you all may know, regulates lactation. It promotes affiliative behavior. It is anxiolytic, and it's released from the posterior pituitary in response to stress. And it does decrease the fight or flight response and decreases cortisol. There's a lot of, one of the things I'd have to say is working with oxytocin, if nothing, I have truly come to appreciate it. The story wasn't as simple as we hoped it would be. There's tons of variability in the oxytocin effect. There's gender differences. For instance, the amygdala response to fearful faces is increased by oxytocin in women, but decreased in men. It varies depending on someone's psychiatric diagnosis or psychological status. And the amygdala response is increased in people with social anxiety disorder by oxytocin. It's It's decreased in social anxiety, it's increased in autism. So it can go one way or the other depending on somebody's psychiatric diagnosis. And it's also very variable depending on context, because oxytocin actually can increase aggression if it's a paradigm where where the group is defending against outsiders. So you can imagine how promoting affiliation might actually increase aggression to outside attackers. So in any case, our first pilot study by Amy McCrae, we were looking at oxytocin before in a stressful situation in marijuana-dependent individuals. It was the social speaking task, the TRIARE. And what you can see here is this is our cortisol response, but if you look, no, this is craving, but cortisol response looks exactly the same. The top bar is those who were administered, the bottom bar is those who were administered oxytocin, top bar is those who were administered placebo. So oxytocin decreased craving, decreased cortisol response, decreased anxiety in this marijuana-dependent group. So we went back to our laboratory friends and said, can you do this in a rodent model, and does it do the same thing? You can see this is cocaine primed reinstatement, no difference between males and females. We were predicting some gender differences. Now we're saying maybe those gender differences are only in stress-induced reinstatement. So that's the series of studies we're doing now. But, then we went on to say, okay, how about in cocaine dependence? If it works in marijuana dependence. So this is a pilot study. Again, same thing, human laboratory paradigm, the TRIARE stress task. Subjects were stratified by those who did and did not have childhood adversity. What we found was overall, oxytocin in this cocaine dependent group did not decrease craving, didn't decrease their stress response. But it did in a subgroup. It had the strongest effects in those who had high childhood adversity. So again, sort of some specificity in the actions of oxytocin. And then more recently, we've just done oxytocin in a conflict resolution task, 33 couples, at least one had substance use disorder, oxytocin versus placebo. Both partners got the same thing. And what we found is that oxytocin in these circumstances really worked only for the women. It increased their positive conflict resolution behavior and decreased their cortisol response. So other new directions, and if you want to hear more about that, there's a PTSD symposium where we have some positive data looking at prazosin, doxazosin in PTSD and substance use disorders. These are drugs that also work on that alpha adrenergic. They're antihypertensives, decrease the tone, and acetylcysteine. We've got some actually very nice data with looking at N-acetylcysteine, which is a glutamatergic drug that regulates the glutamatergic system, which is involved in learning both in PTSD and addictions. And we've got positive data in NAC in alcohol-dependent people with PTSD. But you'll have to come this afternoon to see this. So in conclusion, there's really a strong relationship between stress and substance use disorders. It looks like stressful life events early in life can facilitate the initiation of drug use. It can increase the risk of developing a drug use disorder after initiation, and can definitely trigger relapse. So what are the clinical implications of this? Well, I think they are actually pretty broad. I think we really need to be aggressive. We've gotten better at it, but we could be even more, do more in terms of assessing and aggressively treating co-occurring stress-sensitive disorders. Social support is very important in mediating the effects of stress. We've got some data on that with oxytocin. You really need to carefully assess environmental stress factors such as ongoing stress and abuse. And again, I know we all think we have stress management and coping skills as part of treatment, but I think we could probably really enhance that part of our treatment portfolio, especially for people that have these stress-sensitive disorders, including mindfulness techniques. Therese Colleen, who's here in the audience, and myself, we've got a couple of studies where we're looking at mindfulness relapse prevention in people with and without PTSD and substance use disorders. So I think there's a meaningful connection between stress and addiction neurobiology, and that this meaningful connection actually provides us with therapeutic targets that I think will be very fruitful to explore. With that, I will finish and see if we've got any time for questions. Thank you.